Hello, Dr. Holly Hampy. I'm the Program Director for the Health Administration Program at RMU, and this is our Day in the Life of series. And today we are very fortunate to have AJ Harper. He is from Hospital Council, and he is the president of the organization. And welcome, AJ.
Thank you, Holly.
Appreciate you being there.
Pleasure to be here.
We're going to be talking about his role as the president of Hospital Council and some of the things that he's been involved in. And first of all, how did you become the president of Hospital Council?
Well, I was in Cleveland, Ohio, although I'm from here originally. Most of my career was in Cleveland. I was running a freestanding cancer center and followed the American College of Healthcare Executives website and simply was in there looking at jobs and exploring CEU opportunities and found the opening online for the Hospital Council of Western Pennsylvania. That was 10 years ago this July. Celebrating my 10-year anniversary. So I would say to the students, the American College of Healthcare Executives, a professional organization that provides you with a lot of different opportunities, and one is a job bank, and that's what led me to this position.
So networking is pretty important in the role that you're in, and having a job, getting a job, staying in a job.
Right. Absolutely. Any association, and particularly a regional trade association such as the Hospital Council of Western Pennsylvania, is really one of networking. It's one of facilitation and bringing people together and sharing best practices. So we do a lot of networking, and I would say again to the students throughout your career, it's integral to maintain that network, both professionally and through your professional societies.
Well, you didn't just step into that position. You had a number of things along the way. Can you tell us about your educational background and your experience that prior to becoming president of Hospital Council?
My interest in healthcare actually started being from Beaver County with the old J&L Steel Mill, who had a Health Explorers career opportunities and at the old Aliquippa Hospital, and where you spent every Saturday and went through a different ancillary department to learn about that department. I quickly found that I didn't have an interest in direct patient care, but did still have an interest in hospitals, and so took the route and interest of healthcare administration. Now, as you know, healthcare administration now has a bachelor's degree. At that time, it was only a master's in health administration, so I had to select an undergraduate degree to pursue my course. And so I selected what was at that time known as medical record administration, now known as health information management. And I was interested in that profession because it places an individual across the continuum of the hospital operations. Research with databases, working with physicians, regulatory issues such as Joint Commission, managing individuals, working with finance and reimbursement, the opportunity to provide data and be part of marketing and planning, strategic planning. So it was a great step for me into hospital administration. So I looked at programs and went to the Ohio State University for its program in health information management. And from there, I went to the Cleveland market, where I was an assistant director of health information management, working my way up to a director position. And at that point in time, in 1982, was the beginning of prospective payment, or as you may know it, the implementation of DRGs, diagnostic-related groups. And the entire field and realm of prospective payment offered new opportunities to go in and understand IT systems. It was the automation not of the medical record, but the automation of insurance files, the automation of registration processes, the automation of data registries. And in addition to that, the insurance companies started to do more appeals and denials work. We had the peer review organizations initiated. So my path and career was all through working with medical staff, working with quality assurance, utilization review, survey process, compliance, and gradually over the course of my career, there would be one new regulatory matter after another, the Balanced Budget Act, HIPAA, Y2K. And so my career has always been through the non-revenue generating, non-clinical support side of the house, not finance, but those departments. I eventually went from an inner city hospital to the Cleveland Clinic Foundation, where I spent 13 years and became the Director of Patient Access. And from there, went into the Board of Governors as an administrator, and I was the administrator for medical operations, which was really project-oriented. I worked across all the divisions of the Cleveland Clinic and worked on a variety of patient care projects, workflow redesigns, initiatives with data and quality. It was quite exciting, enjoyed my opportunity there, and then went to the Greater Cleveland Hospital Association, spent 5 years there as the Vice President of Professional Services, which is where I got my association experience. And then back into hospital operations, and as I mentioned, running a freestanding ambulatory cancer center, so I had the hat or the tools of a practice administrator. When I saw that the job was open to come back home to the Hospital Council of Western Pennsylvania, I pursued that. So my career, Holly, has been one of really, again, in the healthcare setting as a health administrator. I had an opportunity to run a few clinical departments, home healthcare services, clinical nutrition, dietary offices, but never really went into allied health or the nursing arena.
You know, one of the things that the students are wondering about is how do you get your first job? How do you make that first step into health administration? And I know you've touched upon it. What do you think was the impetus for you to get that first job? Any words of wisdom on that first entry?
I would say that it may sound outdated, but obviously a solid resume. And then obviously the opportunity to get in and get that interview. And so I would think that internships, networking, whether they're internships paid or unpaid during the course of your work as an undergrad, or if you're already a careerist and you're making a career change or you're pursuing a master's degree, obviously the networking within the organization or entity with which you're currently employed. To be able to reach out to an administrator in another division or a physician leader and to spend time and understand that area or opportunity leads you then to options and for employment and opportunities for that job opening. If you're coming out as an undergrad, it's simply a strong resume, a well-written resume that's going to get the attention of that recruiter, and it's going to be the interview. And for me, Holly, in the end, and I would say to you, all of you, if you end up in the management realm, it's all about communications. It's all about direct communications. It's all about your presentation skills and how to really get in the door. Once you're there, the skill sets that you have, the toolkit that you've put together through your undergraduate learning will then take you where you need to go.
You know, with internships, it's one of those, you know, if it's a chicken or the egg, you have to have experience to get a job, but you have to have a job to have experience. So it's one of those having an internship that will help to bridge the gap between not having enough experience. And I think that you're exactly right. Now, your position as the president of Hospital Council, what does that entail?
Well, first of all, let's explain the Hospital Council, soon to be renamed the Healthcare Council of Western Pennsylvania, to reflect our work in supporting providers across the continuum of care. So as a trade association, we are a 501c3 nonprofit dues-based trade association. You will find that every state has the State Hospital Association, which primarily deals with lobbying on the Hill and the Capitol and working with legislators and regulatory agencies. There are about 21 regional metropolitan associations around the country, of which we are one, and we are more geared towards project management. So our mantra is to convene and facilitate groups. We work off a committee structure, but we really are here to support the C-suite and support key management positions within each of the hospitals, long-term acute care hospitals, and long-term care facilities and specialty hospitals. So again, we're across the continuum of care. As president, obviously my job is to lead that organization, and a lot of my time is spent with the C-suite, with the CEOs, the COOs, the CFOs, trustees, medical staff leaders, and trying to make sure that relationships and issues that occur between members, i.e. providers and purchasers, or providers and payers, are positive as they can be, move fluently. We do a lot, again, as mentioned, project management. We use the words convener and facilitator a lot. So we try to bring groups together, bring members together to share best practices so that individuals can walk away with something learned, some value add they can take back to their individual facility. I have a staff, of course, that does that legwork, but as the president, my job is to really provide that overall leadership and vision to that end.
Now, who would report to you and who do you report to?
Well, we have a relatively small staff. I have a vice president of payer relations and reimbursement. I have a vice president of clinical services. I have a vice president of professional services. It's the four of us in a nutshell. Obviously, payer relations and reimbursement deals with Medicare issues, Medicaid issues, and commercial health plan issues. Professional services individual deals with compliance, risk management, handles communications, advocacy, some lobbying. We do some lobbying, Holly, so that individual leads that initiative. And then my VP of Clinical Services and Quality deals with chief nursing officer issues, regulatory issues from the Department of Health, as well as quality issues. A couple of administrative assistants and a data person, and you can talk about our data reports in a minute, and the maintenance man. So we're small, but very concise, but do a good job. I report to a board of trustees, a board of directors at Hospital Council. That board of directors is made up of 26 individuals. I am the 27th by virtue of the office. The invitations go to the CEOs of the hospital. And if the CEO cannot or doesn't have a desire to participate on the board, we will ask for a chief nursing officer, a chief financial officer, a trustee, a chief medical officer. So we try to get a blend of C-suite individuals to serve on the board. We also have 3 at-large positions, and those are filled currently by the Dean of Nursing at Duquesne, so we try to have academia involved, someone from public policy. We have a physician from the Allegheny County Medical Society. That board meets 4 times a year. They have the fiduciary responsibility, and as president, I report directly to that board.
What are some of the projects that you've been involved in the last year?
Obviously, the Affordable Care Act has been on everyone's mind, and I'm sure we'll have questions specific to the Affordable Care Act before we close today. But it's really, when you look at the projects that we're involved with, we are working with the health plans. We don't do contract negotiations. We don't discuss rates. That's not our role. But we do talk to the health plans about the rollout of certain policies or procedures on quality, on regulatory issues, on reviews, and we try to create relationships there. So we're constantly dealing with the health plans. At the federal level, we have an issue on what is called the Area Wage Index, and to not get into too much detail, it could be a lecture on its own sometime for the students. It is the labor component that makes up the reimbursement rate of the DRG for Medicare. And the wage index varies around the country. It rises from a high of about 1.75 in Northern California to a low of 0.77 in West Virginia. Unfortunately, in Western Pennsylvania and Pittsburgh, we sit at a rate of about 0.85. So, Holly, if 1 is the average, that means at 0.85, you are 15% below the average on the formula to determine the rate for payment for Medicare. So we are constantly working on the wage index issue. There are a lot of flaws in that. This is where we might get into a little bit of lobbying. We work with House reps and state and our senators in an effort to address our concerns about wage index. We work with other state hospital associations. That's taking a lot of my time this past year. It's been a constant project for us. And then basically it's really working with the CEOs and creating relationships. Strategizing. I've done this year a lot of board presentations. Boards are now sitting there, the boards of the respective hospitals or post-acute care providers or specialty hospitals are saying, what's our future? What are some things we should be looking at? AJ, can you tell us about the market nationally? Can you tell us what's happening at the state level? Can you come in and facilitate our board retreat to help us make a decision as to whether we should merge with a nonprofit health system, merge with or be acquired by an investor-owned chain, stay the course, change our service line. So the facilitation skills, which come with good communication skills, Holly, are something that's really been the majority of my work over this past year.
You know, one of the things that we've been talking about is that wage index and why it is different in every state. Could you briefly, why is it that the wage index fluctuates so?
Well, the wage index, obviously, let's take this story of Pittsburgh. In 2002, 2003, the wage index was at about 0.94 or 0.95. It tumbled to where it is today. And as I mentioned, there are wage indices that have a wide range. I believe that in Pittsburgh, there were 2 factors.